Good morning, everybody. Welcome to the live demonstration of our arthroscopic root repair along with centralization procedure. The patient is a 55-year-old female lady who presented with a pain in the knee after an episode of household fall. The X-rays looks almost unremarkable. There is no gross varus here. And if you see the MRI findings are very characteristic here. So if you see the coronal sections, you can see that there is a meniscus extrusion here, and you can see a hyperintensity on the medial most aspect of the tibia, which is called as a medial overloading, and there is an extrusion which is significant. When you go on the posterior images, you will see a sign which is called as a truncation sign. So here you can see that this is a black meniscus, and the black mark, there is a break, or there is a white line there, and this is called as a truncation sign, which is a very characteristic feature of a meniscus root tear, which means that the meniscus root has been avulsed from its insertion on the tibia there and has moved medially. So this is a very characteristic finding in the coronal sections. When we talk about the sagittal sections, you can again see that when we go from medial to lateral, there is a hyperintensity here on the medial side, which signifies a medial overloading phenomenon, which is more anteriorly. As we go posteriorly, we will see what is called as a ghost sign. So if you see here, there should be a meniscus which should be visible here in the posterior horn, but it is not visible nicely. So it's a classical ghost sign which we see in almost 3 images. The other important thing we can see here is an intact ACL, which is very normally seen, and an intact lateral compartment. So if we see the axial sections, so this is the last view. If we see the axial sections, we can appreciate that patellofemoral joint is fine. This is the lateral part, this is the medial part, and here you can see on the tibia there is hyperintensity in this region and hyperintensity in this particular region. That is the anteromedial aspect of the tibia here and here, and this is the region where the extrusion goes and the weight bearing of the joint will go, and this is the first place where the degeneration or osteoarthritis will start on the tibia. That is called as the anteromedial tibial defect or anteromedial tibial loading. And now with this procedure, we are actually targeting to reduce the anteromedial loading. We'll try to centralize the meniscus from anterior, and we'll try to repair the root from the posterior. Now let's proceed to the live surgery per se. Thank you. So good morning, everybody. So we have seen the MRIs, and we know that we need to perform arthroscopic root repair along with centralization procedure. And instead of the conventional transtibial technique, we will be doing this with innovative low profile suture anchor systems. And I'll just be presenting the things that I need for the surgery at present. So this, as I told you, is a very innovative surgery with low profile instrumentation systems, and this is the things that you need for this particular surgery. Now this is what is called as a OsteoKnot-Ex. This is a very low profile extrusion repair anchor. This anchor has got very small sutures, so very thin sutures as compared to any conventional all suture anchor. So this is a number 0 suture which is implanted on a 1.7 mm anchor. That is one. The other thing that we are using, this is called as a RootFix anchor system, and this is a retrograde anchor system, again with number 0 sutures. So they are UHMWPE number 0 sutures, which are very low profile fixation. So instead of the conventional transtibial root repair and the transtibial centralization system, this will give us a lot of modularity to reduce the suture, reduce the meniscus back to its position, and do a very good centralization along with the root repair. We have got a lot of modularities to play while using this anchor. Now this is a drill bit which we use for the OsteoKnot-Ex anchor. You can see it's a very low profile drill here. This is a very important thing that we use. This is called as a loop-in suture. So basically it's nothing but it's a again a wire, and it has a loop on the top, and this is very useful while passing the sutures through the root and passing the threads of the anchor through the root tunnel. So this is again a very important, this is, we call it as a loop in suture. Now this system is a RootFix system. Now the RootFix anchor is the anchor kit comes with a drill, which is a 2.3 mm drill, and it comes with a long spinal needle which can be inserted into the same hole on which we have inserted the drill bit. So drill bit first, and then we can insert the spinal needle directly through the same drill without changing the portals. Now we should have a root repair jig. This one is a Smith & Nephew jig, but you can have an Osteocare OC jig as well. This is a right and left separate, so you can have this sort of a root repair jig, which is very important. You need to have a suture passing system like the First Pass Mini or a knee Scorpion. This is the Scorpion needle. Then you need to have, this is this sort of suture shuttling system. This is an ideal suture shuttle from Mytech, and you can use any sort of this suture shuttle systems to pass the sutures through the meniscus. Apart from this, you need to have your instrumentation set for your shoulder. You need to have penetrator, suture retriever, suture cutters, and knot pusher. So this is basically the shoulder instrument set that you need. So this is what you need on the back table, and these are the cornerstone of a successful meniscus realignment surgery that we are going to perform. Thank you. So let's focus on the surface markings and the surface anatomy for this meniscus realignment surgery. So we need to make a portal on the lateral side. This is our main working portal, which is actually close to the patellar tendon. So we call it a lateral parapatellar portal. This is made blind. The second portal that we make is a anteromedial portal, and this portal is usually made with a spinal needle guidance. So you will see in the surgery that this portal is made with the guidance of the spinal needle from outside in technique. You may need to make it a little bigger portal so that you can insert a 7 to 8 mm cannula for a good suture management, and you need to dilate this portal for a better suture management. Now this portal that I have marked is a very important portal, and this is called as a high anteromedial portal, and this portal is the insertion portal for our extrusion repair anchor. So as I told you, we are doing it with a low profile suture anchor system instead of the conventional transtibial centralization sutures. So for that, to put the anchor into a particular place, we need to make a high anteromedial portal. Now, if you use a high anteromedial portal correctly, you can actually reach the anterior 60% of the tibial plateau, and you can put sutures on the anterior 60% of the tibial plateau. The last 40% of the tibial plateau, you might have to use a retrograde suture anchor. So an antegrade suture anchor for the anterior 60%, that is the OsteoKnot-Ex anchor, and retrograde anchor, that is called as a RootFix anchor, for the posterior 40% of the tibial plateau, will lead to a circumferential reduction sutures that we can put on the meniscus to reduce the meniscus back into its functional position. This is the MCL. So these markings that I have made is the MCL, and a very key step here is to do a meniscus pie crusting. So what is important here is that you mark the MCL, mark the joint line. So supposedly this is the joint line. So you need to do it slightly on the femur and slight posterior to the midline. So if you do it around this region, this will be the magic point, and you will have to do a very less punches. You will be bang on the spot where you need to do the pie crusting. And the pie crusting on the femoral side, I usually recommend. The reason is the healing on the femoral side is little better as compared to the tibial side, and there are no residual laxities when you do it on the femoral side as compared to the tibial side. Although you can do it on both the sides, and you should be doing a very generous pie crusting for doing this procedure without doing any condyle damage. So hope I am clear with my demonstration, preparation, and the surface marking part. Now I'll be doing the live surgery per se, and we'll start by making a lateral parapatellar insertion and doing a diagnostic arthroscopy. Knife please, needle please, needle please. So now we can see the knee joint. You can see that there are wear and tear changes both on the femur and on the tibia. On the femur, you can see some fibrillation, a mixture of outer bridge grade 2 and grade 3 changes. Once we debride it, you might see some grade 4 changes as well. The other thing that you appreciate here is a lot of inflammation here in the meniscotibial attachment site. So this is a very classical finding. If you see meniscotibial inflammation right there, then you know that there are features of meniscotibial subluxation, and you might have to do a meniscotibial release for doing a good reattachment of the meniscus, that is the extrusion repair. Okay, so you can see that it is inflamed shoulder, inflamed knee. So let's start with our portals. Okay, so this is my anteromedial portal, and this portal I always make with the outside in guidance. The exact direction of this portal is very important, because this should be exactly parallel to the meniscus and they should go straight. So you should, that is what the Burkhardt calls, you should shoot straight. So this is little different from my marking, but I need to go by the exact percutaneous marking. So the outside in technique of the portal making is the gold standard here. Sure, please. So at this point, I will do a little bit of so at this point of time, I will be doing a little bit of debridement. And you can see the ACL, which is pristine, which looks good here. And this is my lateral compartment. So the knee looks good on the lateral side. And I need to maybe to remove a little bit of the fat pad, which is blocking my vision. Now, since this is a 55-year-old lady, and we are doing this procedure in order to reduce the arthritic part and to increase the longevity of the knee, we will need to address whatever damages that we see. So you can see an osteophyte here. Now this osteophyte is called as an anvil osteophyte, and occasionally this may cause block to extension, and probably we will do resection of this anvil osteophyte in the end of the procedure. So this anvil osteophyte you can resect. If you want me to resect it right now, I can resect it right now as well. So what I need to do is I just need to change the mode of my shaver and just resect part of this anvil osteophyte with a burring motion of the striker shaver blade. So that is how we can just remove this. Okay, so this is the anvil osteophyte, and we have done a good removal of the okay. So now if you see here, you can see that there are changes of degeneration which is there on the tibia. Okay, now at this point of time we have to do two things. We need to do a release of the MCL, that is the MCL pie crusting, in order to increase the space, and then we need to release the meniscotibial ligaments or the meniscotibial release so as to increase the opening. So what I'll do is I'll just do a little bit of release, or I'll just do a little bit of synovectomy on the peripheral part or the meniscotibial meniscofemoral attachment. And you can see, as I told you, a lot of inflammation here, which is a sign of damage here, and this can lead to increased extrusion in some phenomenon. Okay, so what we want to do is to do a meniscus extrusion reduction here, and for that we need to release these things thoroughly. Okay, stop. So now if you see here, you can see that there are fibrillations here. The meniscus, this part is little mobile. Okay, there was an inflammation here. We cleared part of that inflammation. Now let's do a little bit of pie crusting to open it needle for pie crusting, please. So you can see that now the opening is, so my shaver blade is around 4. So the opening at present is approximately 4 to 6 millimeters. It is little less for doing the procedure. So as I told you, I'll go on to the magic point. New needle, please. So I'll go on to the middle magic point and I'll do the release on the femoral side. And once I do a good pie crusting, you can see that I can open the joint even further. Okay, and this sort of opening I need. So now you can see that my shaver is 4 millimeter and I have around 9 to 10 millimeters of opening, which is actually sufficient for me to work in the circumferential part of the meniscus. Now here you can see that this part is your PCL and the part of root here is totally avulsed. So this, and when the patient load bears or weight bears, this part again shifts medially like this, and thereby whole of the meniscus goes out. The bone touches on the bone, and that's why there is a lot of arthritis changes here. So this is one of the most important pathophysiology of osteoarthritis that previously we didn't know, and now we are understanding that what is the pathophysiology, how does the osteoarthritis starts in presence of a functional or structurally intact meniscus. So what it is basically, if you see RF please. So if you see structurally, the meniscus is intact up. So if you see structurally the meniscus is intact, but functionally it is avulsed from the root. So what happens is when the patient load bears, the meniscus goes on medially, bone touches on the bone, thereby causing a lot of degenerative changes, and this way the degenerative changes progress. Now here, because this is a little bit of old case, I need to do release of the meniscofemoral attachment and the meniscotibial attachment. RF please. So what I'll do is I'll do a release on the periphery of the meniscus. Okay. So this way I am doing a release of the meniscus from anterior to the middle part. By that I would be able to reduce it as far as possible. Stop. As far as possible onto the area where it should be. So I'm just doing a little bit more release. RF please. Stop. So now there is a one important phenomenon, as I told you. Pro please. And these are also additions there, so I'll release that additions also. RF please. Okay, so these additions I have also removed. These are the meniscotibial additions. Stop. And then we will remove the meniscofemoral attachments. RF please. Stop. Chalo. Stop. Chalo. Stop. So we have released the adhesions at the root as well. Okay. Now, if you see, as I told you, the root is torn from here. When the patient weight bears, the meniscus shifts on the medial side, basically the anteromedial side, and this is the area. If you see, you will see the starting of chondral loss on the tibia. So anteromedial part of the tibia is the area where the chondral loss starts, and this is the main culprit area when we start about osteoarthritis, and when we talk about unicondylar knee replacements also, this is the area which is the classical area which is involved in the starting phase. The other thing that I want to emphasize is the damage to the meniscotibial part. So if you see here, you can see, RF Salah please. So we can release a little bit of, stop. RF please. So I am doing a little bit of release of the meniscotibial compartment as well. So I am releasing the meniscotibial ligament as well, so as to make, stop, the meniscus structure more mobile for repair. I'll also go in And I'll just clear a little bit part. Shivachala, please. So I'll just clear a little bit part here also. Stop. Pro, please. So other thing that I would like to show you is when I lift this meniscus up, you will see inflammation here. So again, there is the area of the meniscotibial damage, and this is the area where you will see the meniscotibial ligament which is weakened, and thereby the meniscus will go on to the medial side, which causes the meniscus extrusion. Okay. So by and large, we are done. We are good. We'll just do a little bit of debridement here as well. Sure, please. So we are doing a little bit of debridement here where we want the anchors to be there. Okay, stop. So now the surgical plan will be to repair this root here. RF, please. So the surgical plan, stop. The surgical plan will be to repair this root onto its insertion so that the meniscotibial attachment of the root is restored, and also we would like to repair the meniscus back here so that the meniscus serves its purpose of the loading. That is very important. So now we will be making our high anteromedial portal, which is from right here. Knife, please. Now this high anteromedial portal is used to put the anchors for the extrusion repair, that is the OsteoKnot-Ex anchor, the dedicated extrusion repair anchor that we are using here, low profile, specifically designed for repair of extrusion, small suture threads, very good pull out, small puncture hole which is needed to be made here with this, so much better as compared to the conventional centralizing suture or tape. In fact, these sutures are very strong sutures. Even they are thinner in size, they are very stronger. So what we can do is we can put 1 or 2 anchors here in order to reduce the extrusion. Now I'll ask one of my assistant to go on that side and drill my first anchor for the extrusion. So this is an anteromedial anchor that I am drilling in this particular direction. Thank you. And this is the OsteoKnot-Ex extrusion repair anchor, which is inserted onto its place. This is the most anterior anchor. Okay. And very, very low profile, causing very less damage to the tibia. And now we will be using our devices to pass the sutures along the meniscus and reduce the meniscus extrusion. So this, as I told you, ideal suture shuttles works very nicely here. And what I will do here is I will pass the sutures around the meniscus. This is a point where we need to pass mattress sutures. All the 4 sutures of this anchor needs to be passed. Okay, so what I'll do is I'll take 2 of them initially. So 2 of these sutures are taken here, and the chia is also taken here. And now my assistant can load both of these suture limbs onto the chia here. Okay. And then I can just railroad these sutures Okay, so both of these sutures, you can put an artery there. Both of these sutures have been now passed through the meniscotibial junction. Okay, now we'll pass the other one again on this aspect. Okay, so this is the first one. Okay, so one by one, all the sutures are passed. So if you do this, there will be a good correction of the extrusion. Mhm. Hmm. Okay. All this. And this is my first anchor, and all the 4 sutures have been now passed through the menisco GBL junction. So if you see this technique wise, this is quite similar to the Bankart's repair that we do. The differences are here we are taking sutures in a mattress fashion as compared to the simple sutures that we take for Bankart. Because what I want is, I want to actually reduce my meniscus back into its place. That is more important. So here what I want to do is I want to reduce the meniscus like this into a functional position. Next anchor, please. Next anchor, X fix, please. So the first anchor is in its place. All the 4 suture limbs are in its place. Okay. Now we will be inserting the second OsteoKnot-Ex anchor for okay. Now if you appreciate here, stop. If you appreciate here, I can go with this device, the anti-grade device, up till this part. Okay. So that's what I was telling, that we can achieve almost a repair of around 60% of the tibial plateau by using this anti-grade device. I will not be able to go onto the root because the anchor will skive down, but I will be very nicely able to reach up to the mid body of the tibia if I am doing through this approach. So this is my second anchor, and this is almost on to the tibia. So if you use this anchor properly, you will be able to cover the anterior part and the body of the tibial plateau, and you will be able to achieve a very good centralization of the meniscus into its place. So here we have inserted the second anchor almost on the body center part of the tibial plateau. Okay, if I want, I can do a little bit more back also with this particular, but we'll use a retrograde anchor for the posterior part. Now I'll be using again an ideal suture shuttle to pass tissues from the body of the meniscus. So what I will do is, now I'll go more back. I'll go more posteriorly here to pass sutures through the body of the meniscus per se. So this way, both of these two inside, one here, okay. And again, similar to the Bankart's repair, we are doing this repair for the extrusion, thereby reducing the meniscus into its place. Okay, artery please. Don't forget to put your arteries, because that will guide you where you need to which anchor and which threads, because if sometimes the anchors are more, then you might have confusion about which anchor through which anchor you have passed and through which anchor the suture has not been passed. So this is my okay. So the tying part is done in the end. So what I'm recommending here is we pass both the sutures for the extrusion. We pass everything here and we tie it in the end, because if you tie the first anchor, then you will not have adequate space for passing of your sutures for the second anchor. So I recommend whatever you want to do for the extrusion anchor, you do it together. So tying is in the end after you pass all the sutures of the extrusion repair. Now, some people ask me a question that how is it better than the conventional technique of transtibial centralization? Now, there are many things regarding that. One, the technical part, this is easier to do. The second part is it is quite difficult to drill tunnels in this particular area. So if I have to drill tunnels here, the size of the tunnels is sometimes very less. So if I want to drill tunnels here, the size of the tunnel is occasionally the restriction part. We will not be able to drill the tunnel to a proper place. The tensioning part is always challenging, because if you put tunnels here, then the tensioning of the meniscus is can be a challenge in some scenarios. Okay, so now what I want is I want to repair my root in this part like this, and I want to repair my extrusion in this part like this. Okay, so this is my central anchor, this is my anterior anchor, and okay, so let's start tying these anchors. Cannula please. So we use a 7 mm cannula here to do the tying part. Knife please. So now I'll be using my open the artery please, both the arteries. Green retriever please. So now I'll be just tying my sutures onto their place. So this is my central body anchor, okay, and I'll tie them. So if you appreciate, both of these sutures are very thin sutures. So it is number 0 suture. So there is a very less chance of any abrasion on the cartilage with such thin, small, low profile threads as compared to the conventional tapes that we are using for the centralization. So here we have put the first anchor, tied the first anchor suture, and this is actually on the body part of the meniscus, and this leads to the reduction of the meniscus from a medial position to a more centralized lateral position. Cutter please. Okay, so this first suture, with the first suture we can appreciate that the meniscus is reduced into its place. It's much better placed as compared to what it was when we started. So then we just cut these sutures one by one. Okay, green retriever please. So this is a second, again it is from the second suture. So you tie it onto its place again. So the knot we are using here is a SMC knot. It's a sliding locking knot which can reduce the meniscus nicely to its place. You can use a Duncan's knot as well, or any other sliding knot that you are aware of. Okay, so this is my, so from the second anchor, both the sutures have been tied now. Okay, and the good part now that if you realize that because we have done a release initially, the knots have been sitting into the cleavage, so they are not on to the meniscus, and they are not they will not abrade the cartilage directly, because this is not sitting on the meniscus. They are actually sitting on the cleavage that we have made for the resection of the meniscofemoral and meniscotibial attachment. So it's actually very safe things that if you do like this. Okay, now we have the most anterior meniscus which we need to reduce, but mind you, this is the most important part, as we have realized initially that the anterior part of the meniscus is the most important part which extrudes, and usually most of the if you see most of the extrusion, it is more on the anterior medial part of the meniscus. So I am using my white suture now to repair the extrusion. So again, we are using the same knot. So some people ask me how many anchors that you need to use here. So there is no literature on that. You can use one, you can use two. Some people are also using 3 anchors, but I think 2 is a good number for this kind of case. If you want to do a regular fresh case of a root, you might get away putting a single anchor for extrusion. If you are dealing with such a chronic case, relatively chronic case, then it is usually wise to put 2 anchors, because extrusion here is a lot of forces on the weight bearing, and it is always good to put more fixation points so as to have a good purchase of the meniscus onto the tibia, because here it's not about just healing, but it's about sustaining the healing on a long term part, because occasionally many of these patients may land up into progression of arthritis. So we need to ensure that we do a very solid repair for them, and we also ensure a very good healing of them, of the meniscus, besides doing a repair. So not only the structural part, but the biological part is also equally important. So we are almost done with our extrusion repair part. So we have put 2 anchors, the OsteoKnot-Ex Meniscus Extrusion Repair Anchors, and we have taken, they are all double loaded anchors. So, and we have put 4 sutures. So this is how we are able to close these meniscus nicely over here, and this will actually lead to a very good reduction of the meniscus onto its place. Now what I would do is I would do my exposure on the back. So I may use a little bit more RF and release the posterior part a little bit more. RF please, because I want to increase. So now we are focusing, we are doing our meniscus root repair surgery using our RootFix retrograde anchor. This is a specialized anchor that we have developed for the purposes of root repair, and this anchor gives a lot of versatility in the repair of the root to the surgeon. This anchor is not only low profile, but it is versatile. You can use it in very, very diverse scenarios and circumstances, and you can use this anchor for side to side repairs also. Supposedly if you encounter a radial tear in some cases, you can use this anchor in the radial tear repair as well. So what I do is I will just put my, so we are drilling the meniscus tunnel, meniscus root tunnel. Go. That's it. So you can see that almost it has exited at the perfect position of the root attachment, and from there the system comes with a spinal needle which is long. The spinal needle goes into the same trajectory where you have inserted the drill, and then you can just take out your jig, your bullet like this, and now you can see that it is exactly at the place of the root attachment. Now the system comes with a nitinol wire with the chia. Grasp it please. So the system comes with a nitinol wire with the chia, and when you can see here that the nitinol wire is there. The nitinol, the spinal needle is here. The nitinol wire is here, and I'll just pull the nitinol wire into my place. Now, initially we used to pass the RootFix anchor directly through this wire, but we had breakages of the nitinol wire occasionally. So we have added one more step and added this loop-in suture, which is very strong, and you can pass the wire, the anchor without causing any issues. Now this is the RootFix anchor we have demonstrated. Now this is a retrograde anchor. If you can see, this is a retrograde anchor. This is the pulling suture and it is loaded with 4 sutures, again number 0 sutures. So what I'll do is I will pass it in a retrograde fashion through this, just to be slow in this step. So what we are doing is we are pulling it from the down from the tibia. Okay, this is the anchor which is there. You can see the anchor is there, and you can ask your assistant to pull it. Okay, so it goes in. Okay, it goes in nicely. Okay, so you can see that the anchor is going into its place nicely. So you can see that the anchor is right there, and you need to pull this anchor onto the footprint. Okay, now occasionally if you pull it very hard, this anchor may come out from the tibia. So very good trick is you put your artery here so that you don't over pull it. That's why it does not come out into the tibia. And then you ask your assistant to pull it into the tibia. Pull, please, pull. Pull, 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 pull. Very nice, very nice. Stop. So you can see that it is nicely pulled. Pull again. So very nicely pulled. Okay, so it's very nicely pulled now. So now you can see that the anchor is placed at the root very firmly. Now you ask your assistant to hold this sutures, and then the pulling suture you can pull from beneath. So you can see that this pulling suture, hold it, and this pulling suture we have pulled it from beneath. Now the anchor is subchondral and it has 4 sutures which are exiting from the anchor, and which will be now used to repair the root portion. Now if you want to increase the curate, please. Now if you want to increase the healing, what you can do at this stage is you can curate out the area surrounding the anchor insertion part to increase the healing potential of the anchor per se and for the root per se. Now this is not a compulsory step, but if you want, you can do it at this point of time. Now what I want to do now is to repair these sutures through the root. So we want it to repair through the root. Now you can, the advantage of this particular system is you can use a lot of permutations and combinations to do this repair. So what I am doing right now is I am taking the blue one. This stage, the knee scorpion is a very versatile device. It goes nicely through the posterior horn. If you don't have a knee scorpion, you can use a first pass mini. It is little bulky, but it serves very well. Now regarding the scorpion, you need to be very sure that you use this anchor only, because scorpion will not take anything which is 2-0, which is number 2. So you can take a 2-0 wire through the scorpion, or you can take a number 0 wire through the scorpion. You will not be able to take a number 2 wire through the scorpion. So that is a very important thing. If you are using a thicker suture through the scorpion, your scorpion needle or the scorpion itself may break and can lead to problems of the instrumentation. So it is always important. So this RootFix system is very versatile in that you don't need to use any other thing. You can just use it directly to repair it onto its place. Now here what I am planning to do is sort of a Mason-Allen repair. Okay, so I have passed my first blue suture. Now I will be passing my white suture into its place. So Mason-Allen suture pattern means essentially you need to pass the 3 suture limbs through the meniscus. So the first meniscus we have passed is the suture limb, which is the blue one. The second limb we have passed is the white suture limb, and probably we might pass a third suture limb, which is again white. You can use an artery forceps to hold those sutures which you have passed. curate. Okay. So here you can see that we have passed 2, and I'll passing my last suture through the meniscus root at this stage. Okay, so I'll pass it underneath the meniscus, maybe in this region, probably like this, and we are done. Okay, so we are good. So now what we want to do is we want to tie everything. Now this will be a Mason Allen repair, because we have 2 suture limbs of the white which are in mattress fashion, and 1 suture limb of the blue which is in simple fashion. As I told you, if you want to increase the healing potential here, you might use a curette to do a little bit of curettage at the insertion, so that will increase the healing potential. It is not mandatory because we have already drilled a tunnel, and that will lead to a good repair. At this time you can actually check about the reduction. So since we have done a good release posteriorly, we are able to do a good reduction mediolateral and anterior posterior. So technically we are good, all set for the repair to proceed. You can repair them in any pattern, but I would personally like to do the simple suture first, so that I can reduce the root back to its position. Now when tying the single suture, it is always better if you keep the it is always better if you tie it on the post. So this is, just take it out. Okay, so now we have got the curette, and this curette, as I told you, you can use to prepare the bone in the vicinity. Now the important thing is, don't use the curette before passing the anchor, because if you use it before, you might make the subchondral area weak, and you can have chances of anchor pullouts. But what what I'm doing right now is to prepare the area in the vicinity of the anchor insertion, and I'm preparing it for healing, so that it heals, the meniscus root part heals well. So there is a direct contact of bone at the area of the anchor, and indirect area of the contact nearby to the anchor, which will lead to the good healing. So suction please. So now at this point of time I can just use so at this point of time I can just use the suction to just suck away the parts of the cartilage which we have curated out. Okay, so we'll just use a simple suction to curate away or remove the parts of the cartilage that we have harvested. At this point, we are all set to tie our final suture limbs, and as I told you, I will tie it in a particular sequence. I will use my simple suture first. So this is my simple suture, and this is the first thing that I will use. Tying the simple suture will actually lead to reduction of the meniscus root onto the anchor. So you can see that this portion of the root is mobile, and this portion of the root is coming to the anchor. Now the portion of the suture which is passed through the meniscus is taken as post, because I want to reduce the meniscus root onto the anchor. This is very important. This is what we have taken and we have learned from our cuff. So what we are doing here is we are reducing it. So now the important thing that you realize here is it has got a very small and a very low profile knot. So this is actually very good, very low profile knot that we get in this particular scenario, and it also reduces the meniscus very nicely to its root insertion. So this is my first, the sliding locking knot locks it, and then we can pass 1 or 2 half hitches to actually lock it into its place. So one sliding locking knot, the SMC knot, and after that we will pass 1 or 2 half hitches to lock the meniscus root into its place. So here we have locked it 1 and we have locked it 2. Okay. Cutter please. So now we can just cut the sutures from there. Now with this simple single suture, we can see that the root which was torn is now reduced onto its place, and the second suture, the white one, we will be using this as the mattress suture to hold it into its position. That is what is the purpose of a Mason Allen suture. Now in newer designs of RootFix Anchor, we have replaced this white suture with the green colored suture, so that there is a easiness for the surgeons to identify the suture limb, and the suture management becomes much more easier with the colored suture as compared to this white suture. But this again, structurally this makes a very solid repair. So supposedly if you have a root tear which has a radial component and you have a stump which is lying that on the root, then again this is a very useful modality, because what this technique can do is it can allow you to do a margin convergence, side to side repair, as compared in the conventional transtibial technique. That technique is not available, and you will not be able to do that properly. So here we have again passed the suture, tied the suture in a mattress fashion, and the root is very nicely attached at its position. Both the sutures are very nicely tied, and you can see the root part which is torn is now attached. You cannot even see the part where the root was avulsed, and you can see it's almost like a native normal attachment of the root that you can appreciate. So if you do it properly, you do the meniscus centralization properly, you put the extrusion repairs, anchors properly, you do a root repair properly, your meniscus is intent to come on the functional position, and the osteoarthritis, the chances of osteoarthritis will surely be delayed for the future. So this is the RootFix anchor that we have used, and these are the one OsteoKnot-Ex anchor for the body and one OsteoKnot-Anchor-X for the anterior part of the meniscus. You can combine it with some sort of chondroplasty procedures. If the lesion is big, you can do a mosaicplasty, you can do an ACI for this. Occasionally, some people ask me when I would like to add an HTO. So whenever I am doing these procedures, these two, the extrusion repair and root repair surgeries, I will always be doing. And occasionally, if the varus is more than 5 degrees, I would add an high tibial osteotomy. Now this particular system is a boon if you want to do both the procedures of HTO and the root repair simultaneously, because in this case, just reduce the temperature please. So if you are reduce the temperature please. So if you want to do concomitant osteotomy along with this root repair and extrusion repair procedure, you can do it without worrying about your tunnels, because the fixation of all the anchors is subchondral, and you just forget about these anchors and placement of tunnels, and you just do your high tibial osteotomies and come out. So it becomes a very handy procedure. It's a very good thing for the surgeons not to worry about any tunnels while doing the procedure of high tibial osteotomy. So you can add an high tibial osteotomy to this meniscus realignment procedure if you are doing it for a varus which is more than 5 degrees. So you can just do, after this the surgery you have completed, you can start an HTO. You can do an HTO. This will not only do an angle correction of the osteotomy, but this will also increase or improve the healing rates of the meniscus repair that you have done. So this is the final picture. The first anchor anterior most extrusion repair anchor, the body extrusion repair anchor, and the RootFix anchor for the root repair. A very nice repair, and hopefully we can be able to give a good joint replacement free life to this lady for a long period of time. Thanks a lot for your patient hearing. Thank you.